through a postpartum assessment. So when talking about postpartum assessment, we believe that by the end of this lecture, you will be able to assess a mother who has just given birth, and you will be able to assess her health condition and take action where need be. So when we talk about postnatal assessment, this is a crucial step in ensuring maternal well-being after childbirth, and it helps in monitoring and addressing various aspects of the mother's health during this important period. So the materials that we expect to use, we need to have clean gloves, or we can say disposable gloves. We need to have measuring tape or inch tape. We need to have stethoscope, BP apparatus, thermometer, gauze piece, kidney tray. Those are the ones that we need to have. Then the considerations that we need to make sure that we wash our hands. So hand washing is the first consideration. We have to ensure that there is privacy before we conduct any checkup for the mother. Then adequate lighting, pain pre-medication, because others may require that you touch the mother where she feels pain. For example, if she had the episiotomy and you're going to touch that area where there's episiotomy, it's very important that she has the pain pre-medication. Then avoid exposure to fluids. Protect yourself from exposure to fluids or from touching fluids. Then also avoid uh, uh, okay, avoid exposure to fluids. We have talked about that. Then appropriate documentation is very, very important, and taking action after that. So the vital signs monitoring. Here we take the temperature of the mother, and one thing we need to put in mind that within 24 hours after delivery, there will be slight rise in the temperature of the mother, and this is because of dehydration and the prolactin hormone which is released during this period of time. Then during this period of time, we expect the pulse to remain normal, that is between 50 to 70 beats per minute. Then the blood pressure uh, was previously checked within every after 15 minutes, that is in the second stage, and now we expect that there will be some slight increase immediately after the delivery. So if there is some slight increase, it is normal during this time. Let's look at orthostatic hypotension. So there is likely to be orthostatic hypotension. So it's very, very important for the mother to change the position in case you take the blood pressure and it indicates that it is low. It is very important for the mother to change the position. Then you wait for some minutes before you take again to rule out orthostatic hypotension. The orthostatic hypotension, this is the type of hypotension that can happen based on the position that the mother is in. That is why it's very, very important for her to change the position where necessary. So low blood pressure may indicate late stage hypovolemia. So if the mother still changes position and the blood pressure remains low, it can indicate that during the late stages of labor, the mother might have developed hypovolemia. That could be because of her losing a lot of fluids. That can be related to overbleeding, or to some mothers who vomit, it could be because of that. So when doing the assessment during postnatal, we consider this acronym, BABO-HE. So let us look at BABO-HE. Here we have B stands for the breast, U, the uterus. B, bladder. Then the next B is bowel. Then L for the lochia. Then E for episiotomy, stroke laceration, stroke edema. Then H for hormones or hemorrhoids. Then E for emotional. So let us look at them into details. Let us start with the first B, which is for breast assessment. So here, when doing the breast assessment during postnatal, the mother has to wear gloves before breast examination. Then also assess and make sure that the bra that the mother is putting on is fitting well and it is supporting the breast of the mother well, because a well-fitting bra supports the breast and maintain the breast in shape, and also help to avoid things like breast engorgement, because if it is well fitting, then it will not exert pressure on the breast. Then provides specific recommendations for breastfeeding mothers, bra features. So here, when the mother is choosing the bra, she has to make sure that the straps should be cloth, not elastic, for better support. So the straps of the bra should be cloth, should not be elastic. Those ones that are elastic may end up creating a lot of pressure for the breast. Then the straps should be easily adjustable, should be the ones that the mother can increase the size and they can reduce the size without any problem. Then the back should be wide with at least 3 rows of hooks for fit adjustment. So the rows of hooks that are behind the bra should be at least 3 or more, so that she can be able to adjust, because there are times when the breast will be full, she may need to widen the bra. Then when the breasts are a little bit emptied, she may need to adjust the bra and narrow it a little bit. So ask the woman to remove her bra for breast examination. Then note the size and the shape of the breast. Check for abnormalities, reddened or hot areas and engorgement. Lightly palpate the breast of the mother for any softness, uh, slight firmness, which can be associated with the filling of the breast with the breast milk. Then firmness associated with the engorgement. So this you should be able to differentiate. So if the breast feels slightly firm, it means that they are filling up with breast milk, and this is a good sign. We don't expect that after the delivery of the baby, the breast remains soft throughout. Why? Because they should fill with the breast milk, so that the baby will be able to breastfeed. Then if they are really firm, when you touch they feel hard, that means that there is engorgement taking place. So in case of engorgement, you have to encourage the mother to breastfeed the baby often, to make sure that all that milk that is clotting, that is now packed together, will be emptied out and the breast is left not very hard. Assess the nipples for fissures, cracks, soreness, and inversion. Check the nipples of the breast to make sure that they are not inverted, there are no cracks, there are no fissures on them, and there are no wounds, there are no sores, so that the breasts are in good conditions for the baby to breastfeed. In case of any of these features being detected, then action should be taken. be taken immediately. Teach the woman about breast characteristics and how to recognize problems. So teach the woman that the way the breast should be is this way. Like for instance, we expect the breast to be slightly firm. But if the breasts are too full, they will be feeling hard or they will be feeling firm. If they start feeling firm, please, it is important that you frequently breastfeed the baby to make sure that they are emptied so that you don't end up with engorgement, which, if not counteracted, can lead to uh, abscess, breast abscess, which can become a major problem. Then assess non-breastfeeding mothers for evidence of breast discomfort. Then institutes relief measures can be taken if necessary in case the mothers that are not breastfeeding have evidence of breast discomfort. Then record breast assessment findings immediately for record purposes. Then the next one is the uterus assessment, that is for the letter U. So here let's consider pre-assessment considerations. So the pre-assessment considerations include the following. Breast should be checked after voiding. So after the oh sorry, not breast checked after voiding. So when considering the mother for uterus assessment, you need to make sure that the mother voids first. That means that the mother has to pass urine first to make sure that the bladder is empty, because a full bladder will interfere with the breast examination. So patients should be spine with the legs flexed for muscle relaxation. So the legs of the mother should be flexed to make sure that the muscles of the abdomen are relaxed. So what are the reasons for us to do uterus assessment? We do it to investigate potential causes of uterine atony if present. So when doing uterus palpation or uterus assessment, we can be able to detect if the uterus is contracted or not. So this will determine whether there is a uterine atony or not. So determine the relationship of the fundus to the umbilicus. After delivery, we can determine, before we said that after delivery, immediately after delivery, the fundus of the uterus will be between the umbilicus and the xiphi sternum of the mother. So we do this assessment to determine at which position exactly it is located. Then we do the measurement. Assess the firmness of the fundus. Is it firm as you palpate? Firmness will indicate that it is contracted. Notes whether the fundus is in the midline or displaced to either side of the abdomen. So we note whether the fundus is positioned at its usual position or it is sideways. Locate the position of the uterus if not in the middle line. Then identify a full bladder as the common cause of the displacement. So if the uterus is not positioned in the midline as we expect, then likely the bladder is full, because the full bladder is normally the major cause of this displacement. So let us look at the palpation technique. So palpate the fundus supporting the lower uterine segment above the symphysis pubis. So the way you can see in the picture, the way the health worker is positioning her hands above the fundus, and then the other one is below. So ensure the abdomen is soft, non distended, and the epigastric pain free. So the mother should not be feeling epigastric pain as the examination is taking place. So record the position and the fan low height of the umbilicus, then assess uterine tone. Is it firm or boggy? Boggy means that it is not contracted, and likely it is full of blood clots. Fundal massage. If the uterus is boggy, massage the fundus and observe blood expulsion. Observe the blood being expelled out. Then communicate bogginess or heavy flow to the primary provider. So uh, after after massaging and expelling all the clots out, you need to communicate this to the immediate person. If you're in a center where there's a doctor, it's very, very important so that you involve the doctor in this. So if massage is inevitable, they are ineffective, follow protocol and add medication as ordered. So if you massage and still the uterus uh, is not contracting, is not becoming firm, then it's very, very important to add medication so that the uterus contracts. So after cesarean section, make sure that you palpate the fundus with the extreme care if in women who have had a cesarean birth. Why? Because there is a major wound has been uh, that has been cut on the uterus. So we need to take care so that the mother does not feel major pain. Then inspect the abdominal incision for signs of healing and look for approximation where the edges of the incision appear glued together. So you check to make sure that there is no bleeding that is coming from the wound. Then check for any signs of bleeding and the signs of infection, including drainage, foul odor, or redness. Document the integrity of internal sutures, sterile strips, or staples. So you document to 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 narrate whether the the sutures or whatever that has been used to bring the edges of the wound together is really firm and there is no worry about it. Then review characteristics of normal healing with the woman. Tell the woman about the characteristics of normal healing of the wound. And if she detects anything that is opposite, then she should report immediately. Discuss proper incision care and provide information on signs of infection and when to seek medical attention. Border assessment, that is before fundal assessment. So before you assess the uterus, actually the mother is supposed to have emptied the blood, the bowel. So if she has not emptied, we need to assess it before the assessment of the fundus. Why? Because in case it is full, it can affect also the position of the uterus. So postpartum bowel movements may be painful, especially for mothers who have been given episiotomy. So bowel movements typically run within to return within 2 to 3 days after vaginal childbirth. Why? Because as the baby is being born, there is a lot of pressure that is exerted on the rectum and it normally empties all. So there is nothing that remains in the bowel. So because of that total emptying, it takes 2 to 3 days for it to return. So stool softness may be ordered to increase bulk and moisture, preventing constipation and discomfort. There may be cases of discomfort, may more so for uh, mothers who have been given episiotomy. So if the stools are soft, if they are not hard, then it is easier for them to pass. Preventing constipation is crucial to avoid pressure or sutures and increase the discomfort. Encourage ambulation increase the fluid intake and the additional fresh fruits and refuges to enhance bowel elimination. So we encourage the mother to move around and to take enough fluids to make sure that she does not get any constipation and she can easily do bowel elimination. Information about postpartum diuresis is provided, explaining frequent bladder emptying. So during postpartum period, there is increased diuresis. So because of this, we encourage that the mother should be able to empty the bladder every now and then. More so for mothers who have been given anesthesia, in most cases they will not be able to feel that their bladder is full. But whether she feels that the bladder is full or not, she has to empty, because sometimes uh, the bladder can become hypotonic, where that sensitivity will not be filled. But if it remains full, then it will affect the uterus from contracting. Additional fluid intake is also encouraged. This will help to increase the breast milk so that the mother can breastfeed without any problem. Then discuss signs of urinary retention, overflow voiding, and the symptoms of urinary tract infection. We still continue. Listen to bowel sounds in all four quadrants of the abdomen to make sure that you detect in case there is any problem. Palpate for distension. Inquire about passing flutters or having a bowel movement. Constipation movement. Constipation management as per orders. Then assess diet input and the output and the caloric intake that the mother is taking. So in our local setting, we may not be able to assess this. We may not be able to assess the caloric intake, but we at least make sure that the mother takes what is enough to cater for her needs and also the breastfeeding for the baby. Ensure the patient can urinate regularly, then have the patient void before assessing fundal height and the bladder, and inspect and palpate the bladder while checking the fundal height. Non-fundal deviation suggesting bladder distension can also be noted. We still continue with the bladder assessment. So the nurse carefully monitors the bladder status of a new mother in the hours after birth. Signs of bladder distension, such as boggy or displaced uterus, can be detected, and this should be rectified immediately. Bladder distension can occur as early as 1 to 2 hours after childbirth, more so if the mother has been given enough fluids, and this is also due to postpartum diuresis. Assessment for bladder distension continues until the mother demonstrates complete emptying with each voiding. So we still continue with bladder assessment. So techniques to facilitate voiding may be employed, and this include assisting the woman out of bed to make sure that she can be able to void alone without any support or any help. Catheterization can be ordered if the bladder is distended and the woman cannot avoid the bladder on her own. More so for women who have undergone cesarean section, they may need that support to make sure that the bladder is empty through the catheter before they can do it on their own. The nurse assess the bladder and the voiding pattern frequently before the 8-hour period if the mother hasn't voided. And some women may require catheterization sooner. So women who have had a cesarean birth may have a prophylactic indwelling catheter. So information is elicited from the woman about fluid intake, adequacy of bladder emptying, and the signs of urinary tract infections. The nurse also obtains information about the new mother's intestinal elimination and addresses concerns, including fears about the first-boiled movement being painful because of the bruises that the mother has got during childbirth. Let us look at L, which is the local assessment, and this one is done during Pando assessment. So, assess locia for character, amount, order, and the presence of clots. So, we check for all these. Wear disposable gloves during the assessment. Put on gloves before beginning the assessment or just before assessing the abdomen and fundus, or when ready to assess the perineum and the lochia. During the first 1 to 3 days, lochia should be rubra, and the rubra is the one that is red in color. Sometimes it is known as the red lochia. So note any presence of a few small clots during this period. Clots may indicate inadequate uterine contractions. This means that the blood settles, or the blood stays in the uterine cavity for some time before it is let out, and this mostly happens when the uterus is not contracted. So moderate rubra and small clots are normal in the first few days. Why? Because the the healing has not yet started taking place. The uterus can be firm, but the contractions have not actually sealed it off uh, the injured blood vessels. So there's that blood that keeps on coming. So if it happens within the first few days, it is considered to be normal. But persistent rubra or excessive bleeding, that happens, and that can lead to the filling of the pads within 15 minutes. It means that this is too much bleeding that is happening after childbirth, and it is an indication that the uterus is not contracting well or is not involuting well. It is actually a sign of subinvolution of the uterus. Lochia should not exceed a moderate amount. Partially saturated perineal pads daily with an average of 6 pads. Individual practices and the pad absorbance influence the reported amount. Inquire about pad changing practices. You first find out from the mother. Does the mother let the pad be filled completely with blood before she changes or not? So the frequency of changing is also determined before we conclude that it is postpartum hemorrhage. If heavy bleeding is reported but not seen, the nurse asks the woman to put on a clean perineal pad and reassesses in 1 hour to make sure that she determines whether the blood is really coming in much amounts or not. So to estimate blood loss accurately, we weigh the perineal pads. Typically, 1 gram of soiled blood is equal to 1 ml of blood. So we can equate, because the liquid is the weight of the liquid is equivalent to uh, the kilograms. So if it is 1 liter, then it is likely to be 1 kilogram. So that will help us determine the blood loss. So clots and heavy bleeding may be caused by uterine relaxation, that is uterine atony, retained placental fragments, or cervical laceration, which can require further assessment. With cesarean birth usually have less lock-in after the first 24 hours than those who have vaginal delivery. Why? Because during cesarean section, the doctors have the opportunity to empty everything from the uterus using their gloved fingers. So there are less chances that there will be retained products. So increase the risk for bleeding or actual heavy flow of lochia rubra requires frequent assessment of blood pressure, pulse, and uterus. Physician may prescribe oxytocin or methylgonovine malate, which can be known as methagene if needed. Women with cesarean births usually have less lochia after 24 hours. I think this one we have talked about it. So patient teaching during assessment is very important. And when we are teaching these patients, we have to teach them about the normal changes that happen immediately after when the mother has delivered until she regains her normal life. Then the hygienic measures such as wiping the perineum from front to the back, hand washing after toileting, and changing pads may also be introduced. Then moderate rubra and small clots are normal in the first few days. But if it is persistent, then it means that there is a problem. So individual practices and the pad absorbency influence the reported amount of blood that the mother can report. So this we have looked at then. So let us look at episiotomy or lacerations assessments. Post-cesarean section. Inspect the incision for signs of REDA. So REDA stands for readiness, edema, ecchymosis, discharge, and the approximation. That is what REDA stands for. So when we assess the mother in the post-cesarean section, we are assessing for any readiness, any edema, ecchymosis. Ecchymosis, that means the bruises that happen around that area or around the C-section area. Then any discharge or drainage that is coming from the wound. Then we also look for approximations. Uh, we need to ensure the patient turns to the side of the side for lateral inspection. So the patient should lie on one side to make sure that we do the lateral inspection. Then we also assess the perineum for any signs of REDA and hemorrhoids. Then communicate any concerning findings to the prenatal care giver. Let us look at hormones or hemorrhoids or hematoma or assessment. Um, let's start with the Homan sign. So Homan sign is the type of test that is done to rule out DVT, or what we can call thromboembolism. The DVT can happen in case the mother had varicose veins during pregnancy, and maybe they led to clotting, uh, clotting in those veins. So in most cases, the mother can end up feeling a lot of pain if the hormones test is done. So when doing the hormones test, we tell the mother to lie down and straighten her legs. Then we hold the legs and we do dorsiflexion. If the mother feels pain around uh, the around behind the calf of at the calf of the legs, then she is likely to be having DVT. So we educate the patient on signs and instruct the patient to notify the provider if pain occurs during foot flexion. Then look for signs of unilateral pain, edema, and leg redness. Hemorrhoids and hematoma. Assess the rectal area for hemorrhoids and note the size, number, and the pain. Monitor for localized blood collection, especially within the first 24 to 48 hours. Severe pain uncontrollable by medication may indicate hematoma. Then report any concerning findings to the healthcare team. Emotional assessment. So we assess the mother's emotional status and attachment to the infant. How the mother is associating with the infant. Does she associate freely with the infant or she has some hesitation? They recognize regular postpartum emotional changes. Does she refuse the baby? Does she isolate herself? Does she feel depressed? Such things. Then provide guideline on signs of postpartum depression and when to seek help. Rest and sleep status. We also assess physical fatigue. We assess whether the mother is able to rest and have enough sleep during her postpartum. Physical fatigue that she got during the process of labor may affect her, but is she able to adjust to make sure that she has ample rest? Then fatigue is a significant factor in a new mother's apparent disinterest in her newborn. She will feel like the newborn is interacting with her rest because she has really gone through a lot of stress during the labor and the delivery period. So she feels like she should have enough rest. But here is again a newborn that is in need of care, in need of feeding and other things to be attended to. So how does she react to that? Is there someone who is there to help her during that time? A psychological assessment is done on multiple occasions to avoid misclassifying a tired mother as having any attachment problem. So we do a psychological assessment to find out, is this mother just tired or she is getting detached from the baby. So before we say that she has a psychological problem, we need to rule out that. The nurse also evaluates the amount of rest the new mother is getting during the postpartum assessment. So causes of difficulty sleeping at night are also explored and appropriate nursing measures can be taken to make sure that the mother is supported through this. Laboratory values. So during postpartum period, the leukocytes are likely to be elevated. Physiologic anemia during delivery. So the hemoglobin and hematocrit changes within the first 2 to 3 days and we can return into normal after 80 weeks of good care during postpartum. Activation of clotting factors poses thrombus risk to the mother. So the mother may end up getting some complications. So these ones have to be monitored. Fibrinogen and the ESR may be elevated for 2 weeks, increasing DVT risk. So these ones are actually elevated during the last weeks of pregnancy when the mother is at term in preparation for the labor, because during labor she is going to lose blood. So these factors have to be high to make sure that clotting, the mother does not overbleed. Clotting takes place and she does not overbleed. So during the first 2 weeks after delivery, these factors may remain elevated. Postpartum prevention measures, RH immune globulin can be done for rhesus negative mothers within 72 hours birth to prevent immuno incompatibility in her next pregnancy. Most of those mothers who are all negative and yet their partners are all positive, there's normally that problem of rhesus incompatibility that can lead to loss of the subsequent pregnancies. Then also prevent sensitization of the rhesus positive erythrocytes. This can be done during this period. There is also administration details and precautions that need to be carried out during this period. So let's look at the rubella vaccine and the ROGAM. The rubella vaccine and the ROGAM can also be administered during this period. So timing considerations for rubella vaccine should be done. Then avoid pregnancy post-vaccination. Caution regarding concurrent administration with the ROGAM to prevent ineffectiveness can also be taken into consideration. So that is the end of this lecture. Thank you so much for being together with me from the beginning up to the end. God bless you. Hello? Hello?
I failed to give you the. Let me call you back. Let me call you back.